respected chairman, friends and colleagues. At the outset, I would like to thank Dr. Ravi Shankar, Dr. Debashish, and the Unichem Laboratories for having invited me to join this forum. As an ENT surgeon, almost 40 to 50% of the cases we see are concerned with headache or neuralgia. This is also if we include otalgia. The reason for this is obvious. One has only to look at the region of the head and neck to see that there is a large variety of nerves which are completely giving sensation to this area. Hence, any inflammation which occurs here will present either with a sensation of pain or an ache in the head, as the patient says. Moreover, there is extensive mucosa in this region, and it is this mucosal lining which extends into the sinuses and into the region of the oral cavity and below, which is richly supplied with sensory nerve endings from the cranial nerves, as also from the autonomic nervous system. And it is these nerves which relay both to the areas of the skin and to the region around the ear. When one sees the distribution of the nerves, the skin where it is normally relayed, many of the areas, though well demarcated, overlap with each other, and that makes it more difficult to get the source of the headache. Mainly, the pain is in the distribution of the supraorbital, the infraorbital, and the upper alveolar nerves. And this makes it confusing, as the headache of the neuralgias also occur in the same region. When one looks at the nasal causes of headache, there are many, right from trauma, inflammation, sinusitis, and the neoplasms. However, it is sinusitis which is the most important. Trauma and inflammation are easily recognizable, as normally they present with swelling, and you can see them immediately. It is important to know that if any infection is occurring in the region of the danger area of the face, this should be aggressively treated with antibiotics, and quite often there's a lot of echo, with antibiotics and as well as with mucolytic agents. Why does headache occur in sinusitis? Several causes have been cited. One of the most important is the degree of obstruction. It varies right from slight to moderate and severe to complete obstruction. However, it is not just the degree of obstruction that is important as the cause of the headache, but it is also the site of the obstruction that is even more important. I think we've missed one minute. Huh? No. The headache that we see in sinusitis occurs either in the region of the temporal, frontotemporal, or auriculotemporal regions, in the case of frontal and in the case of maxillary sinusitis. However, in the case of ethmoidal sinusitis or sphenoidal sinusitis, it occurs quite often between the eyes, or it may be in the vertical region, or it may also be in the suboccipital. Most of the other neuralgias, the headache is located to one or other side. It does not in the full area as it is in sinus infections. The ostium of the maxillary sinus is one of the most important sites. This is because there is a large number of sensory nerve endings in this area. And this area has been highlighted by Professor Messer-Klinger from Graz in Austria. And he has said that the main cause of the headache in sinus infections is the theory of mucosal contact. That means contact between different areas of the mucosa. It is this mucosal contact which stimulates the nerve endings and makes the headache relay to the areas in the frontal or frontotemporal regions. If you see this area, which we call the osteomeatal complex, All the major sinuses, the frontal, the ethmoidal, and the maxillary open here. And hence, any obstruction in this area will lead to accumulation of secretions in the sinuses. And once you get accumulation, it may be just trapping of air, trapping of mucus, or the trapping of purulent discharge. Several studies have been done using charcoal to chart out the mucosal pathways, and they show that the mucus always travels towards the natural ostia. Hence, the management of these cases focuses on this region. It is important to use decongestants locally, and this is in fact one of the ways you can diagnose a sinus headache, because the moment you put a pledget of cotton there, the headache and the tenderness disappears. This picture is an endoscopic picture showing you inflammation, and this is the middle turbinate, which is touching both the septum and the uncinate process, thereby causing almost total blockage and headache. So it is the site of blockage that is more important. This diagram shows you that in this area, if there are any anatomical deviations, then the problem is further aggravated. As you can see here, this is a DNS, and this is a concha bullosa. Both of these cause obstruction not only to the maxillary ostium, but also actually to the frontal sinus. And hence these patients, even if you treat them with medical treatment, the chances of recurrence and chronicity are very great. And these are the patients who may sometimes come to surgery and which may give them permanent relief. What are the other characteristics we have to remember? It is often associated with nasal blockage and congestion. It occurs more in the mornings and less in the evening. It is worse on exposure to sunlight. Also, sinus headache aggravates when lying down or in the stooping position. It is relieved with decongestants, and it responds to simple pain relievers, as a lot of the neuralgias do. The problem comes because migraine and sinusitis can coexist. And that is when it's difficult to know how much is the problem due to the sinusitis and what is the degree of problem due to the migraine. This is a comparative chart which shows you how the sinus infections are much more prevalent in all the areas, whereas again the neuralgias are more localized. Endoscopy has ushered in a new era in the diagnosis of headache due to nasal and sinus causes. This again was started by Professor Messer-Klinger, and the nasal endoscopy should now be a part of a routine clinical examination in the ENT surgeon's armamentarium. The role of the CT scan is later, but the CT scan confirms your endoscopic findings, and it will tell you the detailed anatomy as well. This is an endoscopic picture showing you the deviation. When we do an anterior rhinoscopy, we can only see the anterior anterior one-third, of the nasal cavity. We cannot see inside. Whereas here, you can see that there is a complete deviation and causing blockage. Here you can see the concha bullosa. This is what it looks like, and it can be easily recognized on endoscopy. A good algorithm for the management of sinusitis is that you divide it into acute and chronic. Both these infections should be treated initially with medical treatment. However, you can hear. However, acute sinusitis generally responds in 8 to 10 days. If it persists, only then it needs to be subject to nasal endoscopy. Nasal endoscopy should not be done when there is actually acute inflammation, because you would not be able to get the correct information. In the case of chronic sinusitis, however, it's different. Whether the infection improves or persists, the patient should still be subject to nasal endoscopy to rule out the cause of the chronicity. Because if there is no actual problem, then the chances are this may be a neuralgia, or we may be missing a neoplasm. Sorry. Nasal endoscopy is also precedes the CT scan. CT scan is done only if surgery is indicated to know the full anatomy, or it is necessary in case you find you need to know whether there is any residual infection. Here you can see that this is a bilateral conchobillosa, so it confirms your diagnosis. There is some residual infection in the maxillary sinus. It gives us that information. In the case of surgery, it actually tells us the anatomical pathway with...
We like to look at this and...
But the pointer won't show then. That's the problem.
Because the voice is coming down.
Oh, okay. Okay, then I won't choose the pointer. Is that better then? Yeah? It's echoing. It's the only... Okay. Right. So CT scan helps us to find the actual surgical pathway. Chronic adenoiditis has been actually described as an entity, and it is associated with postnasal discharge, headache, and sometimes secretory otitis media. A study done by Rosenfield from Brooklyn has shown that bacterial pathogens are present in 26% of cases, and a lot of the organisms are the beta hemolytic streptococcus and staphylococcus aureus. Adenoidectomy is advocated for them. And a study done by Takashi from Japan has also shown post-adenoidectomy improvement in the headache as over 56 to 60%. Nasal endoscopy also tells us about tumors. And you can see over here that there is a tumor when it comes right up to the nasal anterior nares. At that point of time, it is easy to diagnose. But it is when it is deep inside, like in the Rosenmuller's fossa, that you are unable to diagnose it. It is here that endoscopy has the major, should be done. It's also important in an endoscopy with a patient with an unexplained headache. If you have a look, you can often see a small polyp in the region of the middle meatus, and this may be the cause. The difference between the neuralgias and the ENT causes is that we are able to actually treat the patient and totally cure the patient if the cause is due to the sinus infection or due to any other factors. Why is it jumping? Okay. Right. In the neoplasias, I would like you to just see here and focus on the sinus. The sinuses have large cavities, and the tumor can grow to a fairly large size before it breaks through one of the confines and presents itself either in the oral cavity or in the cheek or in the nose. It is at this stage that it is important to diagnose the case, and here is when it presents either with vague symptoms like infraorbital neuralgia, or it presents sometimes with anesthesia in that region, in the region of the cheek. Sometimes the pain may be in the region of the auriculotemporal joint or due to parotid inflammation. So these are the conditions which we have to remember also and rule out. The oral cavity is next to be seen, and this should be seen both with the view of infections like tonsillitis or pharyngitis or a peritonsil abscess, or the presence of ulcers in the oral cavity, particularly in the tongue. In our country, this is even more important because of the habit of tobacco chewing and because of malignancies which can occur in the oral cavity, and hence a careful, complete examination should be done. It is, however, when all the ENT examination is normal, especially in the case of otalgia, that you have to think of the silent areas in ENT, which may also be the cause of pain and headache. These are the base of the tongue, the vallecula, the piriform fossa, the subglottis, and the ventricle. The mode of relay of the pain to the ear is usually through the auricular branch of the vagus and the tympanic branch of the glossopharyngeal. Lastly, in conclusion, when everything is normal for the ENT surgeon, that is when the problem really arises. Again, like in vertigo and in all forms of medicine, we have been stressing all along, everyone has, that history is of prime importance. This is both in adults and in children. It is important to judge the severity and the nature and the location of the source of the headache, as the cause may lie in any region of the body. In children, it is particularly important as the cause is often organic, and as we have already been told that an MRI or a CT scan may be necessary to make the diagnosis. The general causes have already been dealt with, and it is important in our specialty not only to know about it, but to know about the causes in all the other specialties. And it is for this purpose that I have to congratulate Dr. Ravi Shankar on planning this so that we can all meet on a common forum and discuss this problem. I feel just like in oncology we have clinics, I think a headache clinic with multi-speciality is worth having. And I would like to end with this saying by Munch, that the person with a headache often finds himself a medical orphan. He is fortunate indeed if the headache is transient, for otherwise he may find himself on an excursion to the ophthalmologist, otolaryngologist, neurologist, dentist, psychiatrist, osteopath, and chiropractor. Thereupon he is x-rayed, massaged, analyzed, fitted with glasses, relieved of his turbinates and teeth, and too often emerges with his headache still intact. Thank you.
Thank you, Dr. Hakim, for that interesting talk. Now the session is open. Anybody with questions? Yes, Dr. Amber.
First of all, I'd like to make one comment, and that's teaching, which was imparted many, many years back when I was in neurology training in UK, is acute sinusitis produces acute headache. Recurrent sinusitis produces recurrent headache, but chronic sinusitis never produces chronic headache. So if a patient comes to us, to a neurologist with a chronic headache, forget about sinusitis. Whatever the CT scan or the X-rays might show that the mucosal lining is gone or anything. There is only one exception, and that is a sphenoidal sinus sinusitis. That's a very important thing and very often mixed. It produces severe bursting headache, and you think about tumors, but actually the patient has got a sphenoidal sinus sinusitis which can be detected only on MRI or a CT scan.
Well,
the second thing is, just a moment, the second thing is, what is the cause of headache in sinusitis?
See, the sphenoidal ostium is at a higher level.
Yeah.
So it luckily, because of that, it is not common.
No, it's not common.
Right.
But
it does occur, and usually it presents with a headache which is vertical, or it occurs between the eyes. Sometimes you can get it in the suboccipital region. And when we see with the endoscope, we are able to visualize the ostium of the sphenoidal sinus. So we have seen isolated cases. We have seen the pus coming out of the sphenoidal sinus, and following the endoscopy, which gives us a very good guideline, because you can actually see, then you have a CT scan. If, however, it is normal and the headache is persisting, then of course we do a CT scan, but it is always important, if you are judging it, you must do it with contrast, and then we do a full CT scan with coronal and axial cuts. In a normal sinus, we only do coronal cuts and a limited CT scan. But if a neoplasm is suspected, you have to do it. And the management, if it's an isolated sphenoidal sinusitis, is surgical, because you have to open the ostium and allow the secretions to flow out.
Now, what is the cause of headache in sinusitis?
The cause is this, that is what Professor Messinglinger has said, that the actual mucosal contact is the one which causes the problem. That stimulates the
No,
nerve
that
endings
blocks
and causes the
that
pain.
blocks the ostium. But is it not, there is a term called vacuum headache. That you block the ostium, the air gets trapped inside the sinus,
Yeah,
it gets absorbed,
Correct.
and then the mucosa pulls inside, and then you get a headache. But actually,
No, what I showed there, that the ostium is blocked and then you get a negative pressure.
Yes.
That occurs even in flights and in scuba diving.
yes,
That as well.
Yeah.
In fact, in the old days, we used to do antral puncture for these patients,
Yes.
and they used to get relief. But now it is believed we should not do it because it just precludes to recurrence of the sinus. It's better to open out the ostia and allow the sinus to aerate and drain.
yeah. But you see, what happens is that in patients who have got headache, who are headache prone, like migraineurs,
The headache,
you have any kind of irritation in the fifth nerve distribution that induces the original headache. We did that by experimentation at one stage when I was very young and I had lot more hair, that I removed my hair and put a cube of ice there. I started having a tension type headache to start with, and after some time I got a typical throbbing migraine headache with nausea and all that. So my belief is that most of the headaches in sinusitis is because of the irritation of the fifth nerve in patients who have got a tendency to develop headache, because any irritation of the fifth nerve will produce the same trigeminal-vascular stimulation, and
In
that
fact,
will cause typical
I think
muscular
it-
I
type of-
think this debate would continue never-endingly because
Later, yeah.
no, the point you made is very correct, that unless the same patient is seen simultaneously by 3 specialists, all from different specialities, and the reasons discussed, I think because Dr. Hakim, it might interest you to know that the IHS classification does not believe in the entity of chronic headache.
doesn't not believe in?
The entity of chronic headache due to chronic sinusitis causing headache.
Right.
So acute, yes, but they don't even honor it to that extent. So therefore, this debate is a very
But I would like to clarify, a chronic sinusitis is, when I say chronic, means it is a recurrent sinusitis actually, because it rarely is constant. In fact, they say if it occurs every 2 months or 3 months, you call it recurrent. And in these cases, the headache totally disappears if that blockage is there and you decongest. So
Ravi,
that is one proof that it, one of the causes is mucosal contact. No doubt it stimulates the nerve endings of the trigeminal.
Can I just
Devashish and
make
then-
Yeah.
Devashish, keep it very short. Huh?
Yeah, I'll keep it very short. I mean, with due regard to ma'am and Dr. Francis, and without any malice, you know, the 2 most common things people do with headaches, they go to an ophthalmologist, check the refraction, and the ophthalmologist says, no, आपका eye तो ठीक है, कुछ नहीं, refraction नहीं है. And they go to the ENT people and they will say that, no, you don't have sinusitis, but they don't refer them back to any neurologist or an internist guy. And in fact, there has been a study in America where they have calculated based on the average incidence and prevalence of migraine in a particular area, what should be the total number of migraine cases that should be there in that particular area. And they found the figure to be very low. So they actually investigated that why this migraine is so low in this particular area when the national average is so much. So they found it, most of the people were actually making the diagnosis of sinus headaches and not migraine, which actually were migraine. And when these people were then contacted and taken the history again, all of them have actually been proven to be migraine and they responded to anti-migraine therapy. So therefore, the carry-home message is this: in a given clinical context, with all these symptoms which will be there for the sinus, you can make the sinus headaches as a diagnosis. But otherwise, if the patient is just getting an X-ray or a CT scan with some sinus involvement, please do not make a sinus headache. They're all migraines. Most likely, they're all migraines.
I absolutely agree with you that I think it's very, very important. It's a clinical diagnosis to be confirmed. Only if it clears, then you say it was a sinus headache. If it persists, then it is very unlikely. But I can tell you that in cases where there has been a blockage, we have done surgically, the headache has totally disappeared. But you have to judge, and I don't think CT scan should be done as a first investigation when we get a case. I think diagnostic endoscopy is
Ravi,
the
I'll
answer.
just make half a minute comment.
Brief.
Going with what Debashish is saying, when somebody comes with this diagnosis of recurrent headaches due to sinusitis, be very, you should be very careful. Many of these people have migraine, they take a tablet, Sinarest or whatever, and the headache goes away and they call it sinusitis. So you don't get sinusitis lasting only for a few hours. If you have recurrent sinusitis lasting for a few hours or one day, it is migraine.
Yeah, thank you, Dr. Hakim. Thank you so much. And wonderful.